Hi everyone! Today we are going to cover something that's super important that I find that a lot of families don't really know a lot about when they go into birth, and that is the delivery of the placenta. Did you know that you have choice when it comes to how your placenta is delivered? You have options, and that there are different models of care that can address the way your placenta is delivered. This is a part that often gets so overlooked because the baby comes out and we had so much focus on preparing for the baby and the way the baby was going to be born that often talking about our preferences for delivering the placenta isn't really something that happens. And in the obstetric model of care, it is rare that a provider will ask for what your preferences are or go over step by step what the delivery of the placenta is like. It'll probably just be something that kind of happens to you, and that's what we want to avoid. Birth trauma often stems from feeling very vulnerable while other people are doing things to your body and you don't feel like you have any control or agency or you're not sure what's happening. So this is an important area for you to consider when you're making your birth preference sheet. And I invite you to really get clear on what it is that matters to you, what your values are, and how you want this process to go. So let's talk about the delivery of the placenta and what that can look like. There are two different models of addressing the way that the placenta is delivered. There's active management, which is when the providers are actively doing things, and then there is expectant management, where we're supporting the normal physiologic process to unfold on its own and stepping in if needed. Active management is more common in the hospital, and expectant management is more common in homes and birth centers, but every provider practices differently. So it's not safe to assume that just because you have a midwife, they're going to practice expectant management. So when it comes to active management, the provider is going to take steps to try to get the placenta out to decrease your risk of bleeding and prevent hemorrhage. When your uterus expels the placenta, it's able to clamp down on the open wound left by the placenta where the bleeding is coming from. If the placenta is left inside of the uterus, it could either block blood flow, so you might not see the blood coming out, and that might make it hard for a provider to accurately assess your blood loss. And the uterus can feel boggy with the placenta inside of it, meaning that it's not toning and contracting because the placenta is kind of getting in the way. So having the placenta stay inside of your body for more than 30 minutes increases your risk for hemorrhage. And hemorrhage means that you lose at least 500 milliliters to 1,000 milliliters of more of blood. And that's a lot of blood to lose. So when it comes to assessing blood loss and assessing when someone needs to step in, we shouldn't only be looking at how much blood is lost, but how you're feeling. So with active management, there's going to be a couple different things that they'll do. So after the baby is born, depending on your preferences, they may or may not clamp and cut the cord. But once the cord is done pulsing, likely what will happen is the provider will start to do downward traction on the cord, kind of wiggling it up and down and pulling, hopefully gently, to encourage the placenta to come. No one should be pulling on your placenta if your placenta is still attached to your body. But if the placenta has detached and it's just sitting at the top of the cervix or sitting in the vagina, doing some gentle pulling can help get it out. If it is detached, it's ideal to get it out. But routinely pulling on everyone's cord minutes after the baby is born can definitely come with risks, and it can feel really uncomfortable sometimes. Pulling on the cord comes with the risk of snapping the cord, which could be really dangerous, or leading you to have a prolapsed uterus. This is rare, but it is a risk to aggressive pulling on the cord. Another thing that they may do with active management is after a certain amount of time, often it's 30 minutes, they may say that your placenta is retained and they need to manually remove the placenta. This means that a provider will put their whole hand inside of your vagina, past the cervix, into your uterus, and swipe the placenta like this to clear it from the wall of the uterus and pull it out. This is a very dangerous practice that comes with significant risk, and it can be helpful in very rare circumstances when the placenta has been retained for a long time, or if someone is actively having a bad hemorrhage and they need the placenta to get out in order to save that person's life. So when I looked into different resources trying to get the definition of a retained placenta, what I found is that it is described as being generally seen as retained, or it's generally considered retained after 30 minutes. But I have noticed that there is some acknowledgement that the placenta can stay in for up to an hour. And I know of people who have had the placenta stay in longer than that, but knowing that it can increase your risk for hemorrhage, it's definitely ideal for the placenta to be born soon after birth. So if your placenta has been inside for 30 minutes, by many care providers, they may consider that to be retained. That doesn't mean that you have to consent to them putting their hand in your body and manually removing the placenta. Instead, there are a few different ways to try to get the placenta to come out that you could try first, as long as you're feeling well and you're not bleeding excessively. And if you want to consent to them manually removing your placenta, that's okay too. But it's important to know that that does come with risks, so let's talk about that first. So manual removal of the placenta can lead to infection in the uterus. A retained placenta can lead to postpartum hemorrhage, but manual removal can also lead to excessive bleeding. During the manual removal, there may be some pieces that are left behind, and that can increase the risk for hemorrhage or infection. In rare cases, the manual removal of the placenta can damage the uterine lining, and that can lead to fertility issues in the future. So as you can see, even though these risks are low, the risks are very significant. So if there is a way to get your placenta out without having a provider do it manually, that's definitely ideal. This is the placenta. This is the rough and bumpy side that attaches to your uterine wall, and this is the amniotic sac. When the placenta comes out, it will have pieces of the amniotic sac probably attached to it unless the baby came out en caul, meaning that they came out with the sac around them. There are 2 layers to the amniotic sac, so probably strings of both layers will be attached to the placenta. In very rare circumstances, the placenta can come out and some membranes of the amniotic sac can be left inside. But if anything is left inside your body, it can increase the risk for infection and it can increase the risk for hemorrhage. And that is why after the placenta comes out, care providers inspect it and make sure that there weren't any lobes or anything that was left inside of you. This is the shiny, smooth part where the cord attaches to the placenta. The cord sometimes attaches to the center, but sometimes it can attach around the outside of the placenta, and very rarely in something called a velamentous cord insertion, it can insert actually into the membrane of the bag and the vessels can travel into the placenta. So if you want to gently, by yourself, take the cord that's sticking out of your vagina and hold it and give it just a little gentle pull, really, really gentle. Do not pull the cord hard. If you notice the cord getting longer as you give it gentle pulls and the placenta starts to move downward, you feel more pressure in your vagina, like there's something else you need to push out, that might mean that your placenta is right there and ready. And if you can just get in an upright position and maybe give it a little push, you can give it a gentle pull on the cord, the placenta might come out totally on its own. Getting in upright positions is sometimes all that you need to do to encourage the placenta to come. Another thing you can try is going to the bathroom. Sometimes the bladder and the uterus kind of compete for space, especially if the bladder is full. And one thing that you can do that's really, really helpful for avoiding having your bladder be full when you're trying to deliver the placenta is to pee as much as you can throughout labor, especially during pushing or before you start pushing. So if you can't get the placenta out, you could go sit on the toilet and see if that can help the placenta come on its own, and you can also try to pee. If you don't feel like you can get out of bed, you could just have someone put a Chucks or a towel underneath you and you can just pee on that. Or if you're in the birth tub, you can just pee in the birth tub. Another thing you can talk to your provider about instead of manually removing the placenta is to, after the cord is cut and it's separated from the baby, is to inject some Pitocin into the vessels of the cord and milk it upwards to encourage the Pitocin to get to the placenta. And that can sometimes encourage the placenta to release. You can also talk to them about giving you Pitocin through an IV or as a shot, probably in your thigh, if you're wanting to help get the placenta out and if you're wanting to take steps to prevent bleeding or control bleeding. In an active management philosophy, there will likely be steps that providers are taking to encourage you to get the placenta out sooner by pulling on it, by wanting to manually remove it after a certain amount of time, and by routinely giving you Pitocin in the 3rd stage of labor, meaning before the placenta is out. And Pitocin is a tool that can definitely help get the placenta out. But you don't have to accept Pitocin routinely unless it's something that you want, and we'll talk about that a little more in a second. The next thing you could do to get your placenta out is to latch your baby on your nipple, to do nipple stimulation, snuggle your baby skin to skin, smell them, and kiss your partner, anything that can help your body release oxytocin. If the room is super hectic and there's bright lights and someone's FaceTiming grandma and there's just a lot going on, I invite you to kick a lot of the people out except for the care provider or whoever it is that's taking care of you, and to dim the lights and to go back into that labor space that you wanted to support you in having the release of hormones that are needed for labor to continue. You need the same things to be happening on a biological level for the normal physiologic pathway to allow your placenta to come out and for your uterus to control bleeding and everything like that to happen. So kicking everyone out and snuggling up can really help. And the last tip that I had for you is to talk to your placenta and talk to your body. And just tell your body, okay, body, we did it. Our baby is here. Thank you so much for making this beautiful organ. We don't need it anymore. I thank you and I release you. So now that we've talked about active management and we've talked about some ways to naturally release the placenta if 30 minutes go by and you don't want to manually remove it. Now let's talk about what expectant management looks like. In the expectant management model, we're giving the body an opportunity for the normal physiologic process of getting the placenta to release, of getting your uterus to contract, to all happen on its own. And then there are tools that we can use and we can step in with those tools if needed. But often it's not needed. When the baby is born and they're placed on your belly, skin to skin, the placement of baby on your belly will put pressure on your uterus. The pressure on your uterus will help the uterus to contract, and that will help to deliver the placenta, and it will also help to decrease bleeding. The oxytocin that your body is releasing as your baby is skin to skin with you will also help your uterus to contract, to expel the placenta, and to control bleeding. And you'll get another big surge of oxytocin when your baby latches to your nipple. And that is what's going to really help get the placenta out or control bleeding. In this model, it's often not routine to give someone Pitocin after their baby is born. So Pitocin or other medications like misoprostol and mifepristone can be given if needed, if somebody is bleeding or showing any signs that their bleeding is heavy. Providers often don't wait until someone is hemorrhaging to give them medication. They'll be assessing their blood loss, and if their blood loss starts to look on the heavier side, or if you're not tolerating the amount of blood that you lost well, they will probably step in with medication. Both options are safe and evidence-based options, so it's up to you to make the choice that feels best to you and honors the preferences that you have for this stage. The next thing that I want to talk about is fundal massage. You may have experienced fundal massage if you had a baby in the hospital before. And if you did, you may have experienced it as being something that was very painful and something that you didn't have any choice around. The reason why care providers want to do fundal massage is because when you massage the fundus or the top of the uterus, it helps the uterus to contract, and that can help the uterus to continue to shrink down and also help you slow and stop bleeding. But fundal massage should not be painful. It should not be something that you feel really afraid of, or when you're experiencing, you feel like you're out of control and you're experiencing a lot of pain. That is not necessary. You can massage your own uterus if you want to. You can have your care provider help you feel where your uterus is. You can tell them that you want them to feel very gently, but you'll do your own fundal massage. And it's really only in circumstances where you're hemorrhaging and losing a lot of blood that you need hands to go on your belly to help to save your life, to help massage your uterus to control bleeding. If your bleeding is within the normal range, there's no reason for someone to come in and to cause you any pain. It is good for care providers to assess your uterus and make sure that it's not firm on one side and floppy or boggy on the other side. But this is something you can ask for them to do gently, and you can say that you decline fundal massage, but you're okay with them feeling your uterus gently, or you could feel your uterus yourself and have a conversation with them about it. If your uterus is kind of floppy or boggy on one side, it could possibly indicate that there are blood clots in that area, or there is some tissue left behind from the membranes of the bag or the placenta. And that's something that's good for care providers to be aware of, because that can increase your risk for infection or hemorrhage. But just know that you don't have to accept any routine procedure, whether it is fundal massage, the pulling of the placenta, manual removal of the placenta, giving you Pitocin in the third stage. All of those tools are available to you. They're optional, and there are risks and benefits to all of them. And so ultimately the choice at the end of the day is for you to make. This immediate postpartum experience is sacred. It matters. You being comfortable and supported and feeling cared about by your team, that's important. You have the right to exercise self-agency and make choices throughout this process. You've got this.